These are the X-ray knee joints, including the tibia, frontal projection of a skeletally mature patient, where I can well appreciate that there are multiple ill-defined decencies involving the fibula and with extensive soft tissue swelling associated with it. And multiple air licenses are also noted in the surrounding soft tissues. The licenses seen in the fibula is a have a wide zone of transition,
So
and
this, sorry to interrupt you, this image, the bones are clear.
extensive soft tissue swelling with internal licenses are appreciated on these images.
So what are you thinking? What do you want to do next?
I want to do CT with IV contrast. I am suspecting basically soft tissue abscess formation or infection.
Okay, can you see another screen, or is it the same one?
I can see. In the axial sections of CT scan post contrast images, I can well appreciate that there is extensive soft tissue swelling with surrounding with internal lucencies which were seen on the X-ray, and on a bone window the bones appear. Visualized sections of the bones, tibia and fibula, appear unremarkable. However, the lucencies seen on X-ray are also present in these images.
Okay, so what's your diagnosis?
On basis of these findings, my diagnosis is soft tissue abscess.
Soft tissue abscess, okay. And what do you want to do next?
However, contrast and CT which are available, but I cannot see any. These are also involving the prepatellar compartment and tibiofibular compartment. All compartments are involved in by these air licenses.
Okay, good. So what do you want to do next?
Is there any history of trauma or injury? Then I would.
There's no history of trauma or injury.
Is there any history of diabetes mellitus or something like that?
I'm not sure about diabetes, but the patient had another thing that he was known for. He is a renal transplant patient.
Yeah, means he is immunocompromised. I would advise next. I would advise the administration of antibiotics and drainage of this abscess.
Okay, but what's your diagnosis?
I am again suspecting soft tissue abscess formation.
You are suspecting what? Sorry.
Soft tissue abscess.
Okay, so you did a very good attempt. Very good, excellent. So this one has no differential. Number 1, 2, it's an emergency. So, and this is an entity that you can see anywhere, and you need to be aware of it. So this is necrotizing fasciitis and necrotizing myositis.
Okay.
And you can see it like in the lower limbs. You can see it in multiple places. And this is a renal transplant patient, so he is immunocompromised. So this is an aggressive infection. If you don't take care of it, well, as soon as you saw the radiograph, you need to alert the surgeon, number 1. So when you told me about the radiograph, you would say that there's extensive subcutaneous emphysema, and you're going to tell the surgeon, and you're going to arrange an urgent CT for the patient for confirmation. As soon as the surgeon examines, they would feel crepitation and they would see skin necrosis, bullae, and then the patient can systemically, he can be septic. Like this is that serious. No, this is necrotizing fasciitis and necrotizing myositis. You're mixing two things. So read about this later, and everybody should know about this entity. It is very, very important. That's why I put this, because it is one thing that should not be missed. So you can see the extensive subcutaneous emphysema in all the posterior compartment, basically. And then there's this is the post-op. So you can see that they did debridement, and now there's a little bit residual left, and it didn't extend up. So they controlled it. Otherwise, if it had extended, it could go into the abdomen, anywhere. Yeah. So this was necrotizing myositis and necrotizing fasciitis.
Okay.
Very good. Any other questions to this? You will have to read about this, because you should know this entity, and everyone in part 2 should know about this entity. This is what I feel.
On the grayscale ultrasound image of a postpartum patient, uterus appears bulky, status postpartum, and is a irregular echogenic area is noted in the lower uterine segment. And next, I would like to see the Doppler image.
Okay. Are you talking about this?
Yes, ma'am.
Okay, this is within the fundus, like in the endometrium.
Okay.
Like even if she's postpartum, it's bulk, it's more than expected, right?
Okay. On the Doppler image, there is blood flow is noted within it, and on spectral, there is a venous waveform is noted, and and mixed arterial and venous waveform is noted, and so it might represent AVM formation.
Okay. And what about this?
There is a large lobulated hyperechoic lesion with multiple anechoic areas within it, and it is within the uterine.
Sorry?
Cavity.
It's this is the uterus, this is urinary bladder, and this is present superiorly. I told you she had a cesarean, right?
Yeah, and this is
just describe it, start to describe it, and then you might understand.
There is a hyperechoic oval-shaped area with multiple anechoic areas within it, and it's heterogeneous. And blood flow is noted on color Doppler, and regarding there is also another. This is the same area.
This is the same area, same thing.
Okay. And
so now I'm going to bring this to this image, because here you can see two abnormalities. You can see this and you can see this. So what are you thinking, and what do you want to do?
Ma'am, first of all, I was thinking of AV malformation, and it can be a hyperechoic area close to the, can be a hematoma formation.
Okay, good. Oh, and what else could it be?
Ma'am, can it be scar?
She's recent postpartum, like she is just about within 40 days, or just like that. She's not too away. So the scar period hasn't come yet for her.
Okay.
So what do you want to do next?
Next MR.
You'll do an MR. Okay. So you have an MR here?
I'm on T2 weighted sagittal image. There is ultrascan intensity. area is noted superiorly, and there is a hyperintense signal noted within it, and there is a hypointense rim around that, and
we are talking about this?
Yes, ma'am.
Okay.
And a few signal voids are also noted within it. Might represent blood vessels within it, and it is separate from the uterine cavity, uterus. And
so this, you say that this conforms to this mass, right? This is what we see here.
Yes, ma'am. Yes,
Yeah.
ma'am.
And what about the uterus? What do you see in the uterus?
Ma'am, in uterus there is also altered signal intensity noted in its at its fundal region, because this is hypointense as compared to other.
This one.
Yes, ma'am.
Yeah.
And there is also few signal voids are noted within it. And
signal voids, it's just heterogeneous. Some due to hyperintensity and then hypointensity. Okay.
And fluid in the endometrial cavity is noted. And there is the fat set.
Sorry?
Sorry, ma'am, this axial is post-contrast fat set?
Yeah, post-contrast.
There is no enhancement of the lesion which is outside noted anteriorly or superiorly.
Okay. But what
is peripherally enhancing?
Yes.
And some heterogeneous enhancement is also noted within the lesion.
Yeah, this is her scar. Okay.
And ma'am, if the patient has raised inflammatory markers and history of fever, then it can be a abscess or.
Okay, excellent, good. And what else?
Ma'am, it can be hematoma.
Yeah, hematoma, I'm not going to really say at this stage.
Yes, ma'am.
So this is ACT also for her. Okay. So what are you thinking? What is your thought process here? What are the possibilities? What conditions? Okay, let me put it another way. What conditions are associated with pregnancy? Like she could have post-operative complications. That's number one. Okay. Number two, this thing apparently does not look like a hematoma, right? So what other things would you be thinking of that could go wrong in a pregnancy? Are there any neoplastic conditions associated with the pregnancy?
Ma'am, there can be gestational trophoblastic disease.
Exactly.
And ma'am, other than that, I can't think of any.
Yeah. So what can you see in what is the spectrum of gestational trophoblastic disease then?
Ma'am, their spectrum, ma'am, you are talking about the types?
Types, yeah. So obviously this is not, this is not molar because she is not pregnant anymore. So what are the other?
Ma'am, there can be partial mole, and this can be complete mole, and then
and the baby was fine. So partial and complete
mole out of the list. Ma'am, choriocarcinoma.
Very good. Okay, so in choriocarcinoma, do you know how what you see?
Ma'am, in choriocarcinoma, there is proliferation of the trophoblastic tissue, and it's a malignant. It has a malignant course, and there can be mets in the lungs at the time of presentation.
Okay, so now tell me one thing is that how do you diagnose a choriocarcinoma?
Ma'am, on history of the patient, and then definitely a histological diagnosis.
Is there a blood test you can do?
Yes, ma'am. Serum markers.
What?
Ma'am, sorry. It's I just forgot the name.
Beta ECG.
Beta ECG, yes, ma'am.
So in this patient, what happened is that when they saw these findings, this is not a hematoma. This is hemorrhagic. So that's why you're confusing for a hematoma. But you saw the vascularity, you saw that it's enhancing. So it's not a hematoma, right? This is the main point to catch in this is that we do. So when you're thinking of, I told you that she's postpartum. So immediately it should come, okay, it was very good. You said post-op complications. I said, no, she didn't have any post-op complications. And then what other, there are very less possibilities. She didn't have anything before pregnancy. So then you have to think about these gestational trophoblastic diseases. This is choriocarcinoma, metastatic. You can see the lung mets, and there's an incidental finding in the lungs. Do you see all that ground glass, all that? Airspace disease. So this was chemotherapy-induced pneumonitis due to cyclophosphamide and methotrexate. So this is actually choriocarcinoma case, but very interesting and very so when we did 2 ultrasounds for this patient, we did 1 ultrasound and she came with abdominal pain and it was reported as probable hematoma and the patient was signed off. She came back again and then they did the second ultrasound and this thing had enlarged. And then so they said that we need to investigate further. Then she had MR, CT, everything. And so this is a case of choriocarcinoma. I found this really very interesting.
And it's outside the uterus. That's why I was so confused.
Yeah. So this is, she has mets. She has other mets also. She has in the lungs. She has in the abdomen. So,
okay.
Yeah. So good case. Good. Very good attempt.
Okay. So are you going to scroll for me? Axial images first?
Yeah.
Okay. I can. Actually, this is urinary bladder. These are images through the lower abdomen. There are some free specks of air noted in the mesorectal fascia and in the peritoneal cavity, along with a small amount of free intraperitoneal fluid.
Yeah.
Moreover, there is associated fat stranding also seen. Free air is also seen in the just below the anteabdominal, so that's pneumoperitoneum. Okay. So
pneumoperitoneum or retroperitoneum?
I think that there are both present in this case.
Okay.
Okay.
How can you confirm? What do you want me to do on this image to confirm?
Lung window? Yes.
Yes. Okay. So now you want to see where the air is?
Can you please scroll axial images?
Yeah.
Again. Okay, there is subcutaneous here as well.
Sometimes it's difficult to tell, but with this much amount of air, there's nothing here. See, there's nothing here. So it is not in the peritoneum.
Okay, so that
and it is mostly along the vessels. It's mostly subcutaneous. It's around the rectum. So,
okay,
so now what are you?
Sorry? I was just confusing. That's a bowel loop just behind the anteabdominal wall.
Let me bring the. Okay. Okay. So which bowel loop are you saying? This one? No, that's just free air.
Okay, so that's extraperitoneal.
Yeah.
Okay, so that must be all. That's also seen going into the inguinal canal, I think.
Yeah. Yes. Yes.
Okay. I suspect that there is a perforation in the rectal wall.
Okay.
And there is a diffuse thickening and enhancement also present in rectum.
Yeah.
Okay, free air also seen within uterus.
Okay. So what would you be thinking? What would be the cause?
I'm suspecting that whether there might have been some rectal uterine fistula developed secondary to some infective or inflammatory pathology, primarily of rectum.
Sure. She didn't have any known conditions to develop a fistula. So what other thing would you be thinking of? You did the case really well. So you just have to tell me the diagnosis. You're just one short.
Okay.
What other cause of rectal perforation could there be?
She's a young patient, so yes. There isn't any history of radiation.
No.
Okay. Rectal perforation. Did you specify any history for me? Only?
No, I didn't give you any history. I withheld it.
Okay.
I'm just asking you what could be the causes. So the causes could be a foreign body that could have caused it. The causes could be trauma.
Yes.
Right? So this patient had a ski accident. Skiing when they ski in the ice. So that's what.
Yes.
And she had a rectal perforation. And you can see this is all blood actually, because she was transported from somewhere. So by the time she came, all this is blood. So, and that was rectal perforation. One thing I would have wanted you to see also was that there's also air in the vagina. So actually her vagina was also, it was a rectovaginal actually.
Okay.
Yeah. So, and what do you want to do next for this patient?
I would also like to review the bone window images.
No, we can leave that. Because she didn't have any trauma to the bones. There wasn't any. So I just said, what do you want to do next?
She needs immediate surgical referral.
Okay. Surgical consult. Okay.
Yeah. And rectal contrast can be administered to further.
I think that the imaging has told us that she has a fistula. So we leave it to the surgeons. We don't always have to say to do an investigation. It's not necessary. We have to say the appropriate investigation, if you understand what I mean. So surgical consult is appropriate. And then if they want to do something further, they're going to tell us. So very good. Excellent attempt.
Okay, this is CT abdomen, post-contrast images, which I can see that there is the stomach is markedly distended, and okay, ma'am, please scroll again. A few specks of calcifications, or I suspect few specks of calcifications in the posterior aspect of the stomach. I suspect these to be in the tail of the pancreas, however. So, okay, and I would like to see...
Pancreas is probably okay, but we don't see it well because the stomach is so much distended. Everything is really not exactly where it should be. So I would leave the pancreas alone.
Okay. So there is peripheral aspects of calcification, which I will confirm on the plain scan. As these are
there's no plain scan, and there are no calcifications.
Okay, so there are dense foci. Okay. Noted in the stomach. Stomach is grossly distended and visualized. Kidneys are normal. Ma'am, can you scroll again? If the patient has some history of surgery?
Head surgery, but we can ignore that. That was something the patient had and it was stable. There was no issues with that. So what is the main finding you see? Like something that is popping out at you when you're looking, okay, look at this image, just focus here. So what do you see here?
Ma'am, in the corners?
Like this part, just this. So what do you see here?
Ma'am, there's a heterogeneous density area is noted in the.
What is this? This is a massively distended stomach.
Yeah. And
when it is this much distended, you're going to see this is just mottled internal content, probably what she's been eating. Okay. So we just disregard that, but this is the main thing. So what's happening to the stomach? Why is it distended? What important points do you want to look in this image?
Ma'am, I want to look at the pyloric region, if there is any constriction over there. Or if,
I think the pyloric region should be somewhere here because it's so much distended that everything is not as it should be. So this is probably duodenum, second part of the duodenum.
It also appears distended. So, ma'am, distally, ma'am, can you please scroll distally?
Yes.
And okay, below the third part and the rest of the bowel is not distended. So in a young patient, I will consider annular pancreas. That has caused proximal distension, so much distension of the second part of the duodenum, and as I cannot appreciate any mass lesion in these images.
So what's your diagnosis and what is your management?
Okay. Ma'am, surgical referral should be done. My diagnosis is of annular pancreas.
Patient is in the emergency. The surgeon is going to come after. What do you want to do before that?
Ma'am, I'll pass an NG tube.
That is very appropriate. You must say that NG decompression should strongly be considered given the massively dilated stomach. And so there's one important diagnosis you might consider.
Okay. Ma'am, in the differential, you want to ask? I've given my diagnosis of annular pancreas and so, okay. The other, it can be, ma'am, any intraluminal lesion, which I'm not,
no,
I cannot see over here.
No.
Ma'am,
this is on this image. In your description, what I would have liked is it's distended. So you'd have said something about ischemia. Do you see, whenever you see bowel, you must look for ischemia, always. Because that is one cause that you need to exclude every time. So there is nothing like emphysema in the stomach. The only thing is that it's distended, right? Where is the transition point, which is the second point? Whenever you see bowel obstructions, small bowel, stomach, wherever, you have to look for a transition point. Where is that?
Okay.
The transition point is on this axial image.
On this axial image, ma'am, I think that, ma'am, the second part of the duodenum.
This is the second part of the duodenum. This is the third, and then the fourth here somewhere. This probably.
Yes. So, ma'am, the third one is not that. Okay. Ma'am, there's another thing. Ma'am, SMA syndrome can also cause this.
Yes. So what do you see in an SMA syndrome?
Ma'am, the superior mesenteric artery passes. Ma'am, duodenum, third part of the pass. Ma'am, I'm getting confused.
You are absolutely right. You can read about it later, but this is SMA syndrome, and the patient acutely presented with like obstruction. So look at her body. See how thin and anorexic she is. There's hardly any fat. So that's why we're having difficulty in seeing also. So this is because of this was an SMA syndrome. Look at the SMA. Do you see it like this? Look at the angulation.
Yes, the angle is reduced. Yes.
Yeah. So this because she doesn't have she has severe weight loss, and then you see that there is the SMA is literally as if it's compressing. You can hardly make out the normal angulation that we see with the SMA. So there are many causes of this. It could be due to it is associated with anorexia, malabsorption, congestive heart failure, other causes also. And then, so for this, you just need to, this is what we suspected, and this was what it proved to be. And NG decompression should be done for this, but you need to say that there's no ischemia and it's significantly distended. And then the bowel distal to the SMA, look at that. So you can see that. See that? See
Yes,
that? It is absolutely normal. So this was SMA syndrome. Is SMA syndrome. And normally the angle should be, I think, 28 to 65 or something like that. And then this one is significantly reduced. The aortomesenteric angle, hardly any angle actually. So this is that. Very excellent. You did well.
Thank you.
Okay. I'm provided with extra chest frontal projection, which is including the upper part of abdomen as well. And I can see the opacification of the biliary tree, which is probably due to any barium study. And a chest lead is also noted. Okay, in X-ray chest, the lung fields are hyperinflated, and however they are clear. The trachea is central. The mediastinum is unremarkable. The hyla are prominent bilaterally.
Okay, so what is the difference between this radiograph and this radiograph? One big difference. This one, right?
The upper one, madam.
This is new, right? This is old, and so this is new. So what's happening here?
Madam, I think I'm unable to find any difference between the two.
No, what is this?
Sorry, can't see. Please do this again. Point again.
What is this?
Madam, this is. I said previously that it may be any contrast in the biliary tree.
Yeah. So what is the cause of this contrast in the biliary tree? I want you to find it on this image for me.
Okay. So this is probably percutaneous cholecystography done or an ERCP done.
Okay, so what is this?
This is.
When do you place what is the indication?
This is central line.
No, it has a name. This is something.
Okay, this is cath, porta cath.
Porta cath. Why do you put a porta cath?
It is put due to instill chemotherapeutic agents or
So then what does that mean?
The patient is undergoing. The patient is having any malignancy, and she is undergoing chemotherapy. And,
but then what is this?
Okay. On the visualized images of the okay, this is CT chest, CT abdomen, axial projection, axial view.
This is CT, MR, and MR.
Okay, sorry. This is MR T2 weighted images.
This is post contrast. This is subtracted, so that you the subtracted images are done so that you can see the enhancement or whether there is or there's not. And this is a T2 because you can tell from this, right? So this is a T2. And
Okay.
this is a CT of the same patient.
Okay. Will you scroll the first image?
Sure.
The CT image, sorry, the CT image.
Yeah.
Okay, on the CT images, I can see that there are multiple fluid, there are multiple dilated channels within the liver, which are
these are heterogeneous hypodense lesions. They are not communicating with anything. They are by themselves because you can see the vessels.
Yes.
And the bile ducts are not dilated. So there are multiple hypodense, but they're heterogeneous. You can see a bit of
hypodense lesions within the liver, which are showing subtle intravenous contrast enhancement as well.
Mm-hmm.
And on MR post contrast images, the lesions, they are again showing subtle post contrast enhancement, and they are randomly scattered within the liver, mainly the right lobe.
So what are you thinking this is? What could it be?
They can be multifocal HCC or liver metastasis.
Yeah, exactly. And so then what did you see on the chest X-ray? What could be a cause? She's a female.
Yes.
So what are the possible causes?
I can see radiodense lesion in the right breast.
That was an implant, breast implant, but that is not the cause. So this patient, she had chemoembolization because she had multiple hepatic mets from a colorectal cancer. And this is a potacath.
So this is TACE basically, the lipoidal
embolization, exactly. Embolization, pre-embolization prior to surgery. They did that, and this is a potacath.
Okay.
Yeah. So you just need to be well versed with tubes and lines. As soon as you see this potacath, you should know she has a malignancy. You just have to say female. You could say breast. What other most common is colorectal. And we do chemoembolization of colorectal. It could be HCC, very rightly said. They could have done chemoembolization for that, but this was colorectal. Very good.